Hi everyone. So one of our last modules, we are going to be talking about very basic aspects of performing a venous leg or a DVT study. We will be coming back to this in much more detail, in more depth in the fall when we have our vascular class. That is not to say that you don't need to know this stuff now. You guys are going to be starting the summer semester very quickly. You're going to be in clinic for 4 days per week. You are going to see a lot of DVT studies specifically in the legs. So you have to have a strong understanding of the basic information that pertains to this very specific exam. So we're going to talk about some reasons why we perform a DVT study, what a DVT actually is, how we do it, and some rules that are applied to these exams. Anything in the vascular world. So we're starting off with venous legs, but there's also venous arms that we evaluate. Then there's arterial legs, arterial arms, carotid artery exams, Doppler exams. Anything that is considered a vascular exam is going to be very different than a general exam that we're used to scanning. Protocols are different, techniques are different, we're implementing different things because the cardiovascular system is so functional. So very briefly, talking about venous physiology, what is that overall function? The purpose of the venous system. We know it's going to be hand in hand with the arterial system. But the purpose is to return all of the deoxygenated blood and all of the waste products back to the heart so that it can be filtered. So arterial blood is taking oxygen-rich, nutrient-rich blood from the heart to the distal tissues. Venous tissue is scooping it up from those distal tissues and then bringing it back to the heart. So if you've seen a DVT study performed in clinic before, you've probably noticed that when they're at the top of the patient's leg, they call it prox. When they're at the mid leg, they call it mid. And when they're down closer to the knee, they call it distal. Anatomically, that's incorrect. Our venous system originates at the distal tissues because of the relationship that it has with the arterial system. So our arterial system originates at the heart, right? Travels through the aorta, breaks off into smaller tissues. So the heart is the proximal portion of the arterial system. Travels distally towards those tissues, those fingertips, those toes, whatever it may be. And then the very proximal origination of the venous system is going to be right where it communicates with that distal arterial system. So the distal arterial tissues are going to then turn into the proximal venous tissues. And it does so through this capillary network. So we'll see that on our next slide, kind of to help us visualize what these two systems look like in terms of working hand in hand. The venous system is low pressure, right? Anything that's our arterial system is going to be higher pressure because it's coming from that driving force of the cardiac contraction in our heart. So our heart says, hey, I got to shoot this blood out, and I have to make sure that it has enough force and pressure to get to those distal tissues appropriately, because those tissues need this oxygen, needs these nutrients. Our venous system says, okay, hard part's over, right? The tissue's got the oxygen and the nutrients that they need. And now I'm just kind of here like cleaning up, right? Kind of like janitorial services here, like low pressure, gonna get the job done, gonna get everything nice and clean back to normal, back to where it needs to go. The hemodynamics of the venous system are going to be very heavily influenced by any sort of pressure change throughout the body. And that is going to be done through a lot of different factors. Our breathing changes our hemodynamics, right? Our breathing changes the pressure in our venous system. Gravity, so whether we're laying down or we're standing, whether we're running or we're sitting. Immobility has a huge influence on pressure. Cardiovascular disease, so if there's something wrong with our arterial system, there's probably going to be something wrong with our venous system, right? So the two are not mutually exclusive from each other. We've probably seen some of these differences in pressure when we're looking at the IVC and the aorta, right? So our IVC is easily compressible, right? It doesn't really contract rhythmically. So it's much more kind of go with the flow, kind of like that lazy river. But if you are the arterial system, if you're the aorta, we're not going to see a lot of pressure changes because it's constantly under a high pressure state. So we're not going to see this kind of lackadaisical change in diameter. We are going to see very rhythmic pulsatility and kind of continuous diameter changes because it's always going through the same amount of pressure with each cardiac contraction. So try to bear with me. Some of this should be a little bit not repetitive, but be a little bit of a refresher from anatomy and physiology. But I want to make sure you guys have a very good, strong understanding of this and the relationship of the venous system, what makes it different from the arterial, and how that comes into play with our patients. So venous anatomy, like we said, very easily compressible because it is a low pressure system, right? We don't have a ton of pressure on our veins, within our veins, so the walls can compress. The lumen can compress because of that. It's going to represent continuous phasic flow. Continuous meaning there's always going to be blood flow just traveling back, right? Think of like a conveyor belt. It's just always going, right? Always kind of the same speed. Speed doesn't change. There's really no hiccups with a conveyor belt. Because of that, because we have easily compressible, continuous flow, response to pressure changes, the wall composition of the vein is going to be very different than it is compared to the artery. So the artery is constant high pressure state. It has to have a very thick, strong middle layer, right? That medial layer is going to be much thicker, much more elastic in an artery than it is in a vein. We don't need it to be strong enough to withstand pressure. We need it to go with the flow. So the layers of the the layers of the vein are going to still be similar in their name and their location. We're still going to have a tunica intima, media, and adventitia, but the composition of them is going to be very different. That middle layer in a vein is going to be more equivalent to the intima and the adventitia, whereas in the artery, that media layer is much thicker and has much more responsibility than the other two. In addition to those 3 layers, we do have the vasa vasorum. So that's going to be like this little tiny network of blood vessels that supply the outer wall of the blood vessel. So our arteries have a vasa vasorum and our veins have a vasa vasorum. Anything that's a functional tissue needs to have blood supply. So our arteries and our veins are no different. They're functional tissues. Our veins are going to be unique in that they have valves, and the valves serve a very, very big purpose. They're going to be an extension of that intimal layer, so they're going to extend from the wall inward into the lumen of the vessel. Because the vein is a low pressure system, and because it kind of represents this continuous go with the flow type flow, we have these valves in there to help us prevent backflow. So think of like if you are on a roller coaster and you got a big hill coming up and you don't get enough speed, which is like horrifying, right? Because no one wants to be on a roller coaster that's like not working appropriately. But you're on the roller coaster, you're trying to go up the hill, and it's like, oh my gosh, we didn't have enough speed, we didn't have enough force to get to the top of the hill. So now you go backwards. That's going to be the same thing that can happen in our veins. Our valves help us to prevent that excessive backflow of fluid. Now, we said proximal veins start very distally. They start far away from our body. So they start in our toes specifically. We're going to use this as our example. We're mainly focusing on the legs. Our veins start in our toes. So it says, okay, I'm deoxygenated, waste-filled blood, and I'm in the toes right now, and I have to get all the way back up to the heart. So I have to fight against gravity in a low-pressure system to help get upwards to the heart. So there are a lot of factors that are working against that venous blood that are going to try to prevent it from getting back to the heart where it should go. So the valves are kind of like a little boost that say, yep, keep going, and don't worry, if you fall back a little bit, I'm right here to catch you. You're not going to go all the way back down to the toes. So when we have valve insufficiency or we have something abnormal happening with our valves, that's when we get into a lot of complications with our venous system, venous disease, venous pathologies. We will learn more about the importance of the valves in the fall, but it is a big indicator as to why we would be performing some of these exams. We do also have, I will mention very quickly, we do have muscles that are specifically dedicated to helping with the blood flow back up to the heart in our legs. So our gastroc muscles, those are going to help us that as we're walking or as we're standing and we have extra gravity on our toes, those muscles will help to squeeze that blood flow back to the heart. So we don't have the driving force of cardiac contraction to help us drive that force back to the heart, but we do have muscles that serve the purpose to contract and to put pressure on the vein to shoot the blood back up through those valves back to the heart. So hopefully that all made sense, but please take a second, try to digest that, and then we'll move forward. So our systemic anatomy, like we said, working proximal to distal. Proximal is going to be our distal tissues in terms of relational anatomy. So we are going to start in our proximal venous system with our digital veins. Digital is talking about our digits, our fingers and our toes. We're mainly focusing on the feet here, the legs, the feet, the toes. So we're having our digital veins. Those will join together, right? We typically will have 5. Sometimes we'll have 10, depending on which version we're talking about. Some of them are typically going to be paired per toe. And then they're going to join together as they travel through the foot, and they're going to become metatarsal veins. We should be familiar with some of these terms here, even though they are skeletal terms. We do have to be aware of our bone anatomy and terminology when we're talking about the vascular system. So veins in our toes join together. They form larger metatarsal veins, which are still going to be in the foot. Those metatarsal veins are going to communicate with plantar arches. We are going to spend a lot of time talking about plantar in the feet and palmar in the hand, arches in our vascular class. It's a very complicated network of arterial and venous blood flow and the relationship between what happens in the hands and what happens in the feet. Now, moving up into the calf, so now we're kind of at the ankle, we're going to have 2 posterior tibial veins and 2 perineal veins. These are both going to run posteriorly on the leg, and the perineal veins are actually going to be located a little bit deeper into the muscle of the calf than the posterior tibial veins are. Use these words, start familiarizing yourself with some of these terms, right? Tibial, we're going to be near the tibial bone. We're going to be near the tibia, right? Posterior to the tibia, we're going to be behind the leg, behind the calf. In addition to 2 posterior tibial and 2 perineal veins, we also have 2 anterior tibial veins. Now, the anterior tibial veins are going to be kind of in a little ballpark of their own in terms of calf veins in general. So for straightforward calf veins, we have 2 posterior tib, 2 perineal, 2 anterior tib. Usually in clinic, we don't evaluate the anterior tibial because they're kind of in a ballpark of their own. Those are going to run along the anterior aspect of the tibial bone. Now, in addition to those calf veins, which we typically consider superficial veins, we also have these highly, I don't want to say questionable, but highly, there's like varying literature on whether or not the gastroc veins or the gastrocnemius veins are considered deep or superficial veins. And we'll talk about the classifications between deep and superficial in a second. Deep is a little bit more important. Typically has a direct extension to the heart, so that's where we get concerned. So in our calf, we have superficial calf veins, 2 posterior tib, 2 perineal, 2 anterior tib. Out of those 6, we care the most about posterior tib and perineal. In addition, still in the calf, we have medial gastrocnemius vein and a lateral gastrocnemius vein. Now, these are not just one vein. It's more so one vein that represents all of the drainage that happened within the gastrocnemius muscle, whether it's on the medial side or the lateral side. So sometimes we'll just see one medial gastroc vein and one lateral gastroc vein, depending on our patient, depending on where we're looking and the level in the calf in which we're looking. Other times we might see all of those little draining veins that come together to form the medial or the lateral gastroc vein. So we will come back to all of this, but I'll be very happy if you guys can fully grasp this. Now we're working our way up the calf. So now we're towards the back of the calf and we're pretty much in the area behind the knee. So all of those vessels are going to join together. Posterior tib, perineal, anterior tib, medial gastroc, lateral gastroc, they're all going to converge together and now become the popliteal vein. One vein, that's it, behind the knee, runs for a short section. As we travel up the thigh, that popliteal vein is now going to be considered our femoral vein. Now, again, varying literature on this, varying terminology depending on where you work and radiologist preference. There are some places that call the main femoral vein in our thigh the superficial femoral vein, which is confusing because it's not considered a superficial vein. It is a deep vein. So we're trying to move away from that terminology and we're trying to call it just the femoral vein, right? Because that's the main thing that we're looking at is this femoral vein that's going to run up and down our femur, right? Our thigh. So you may see people annotate SFV. That stands for superficial femoral vein, but it's highly confusing because it is not a superficial vein. And we're not going to right now get into why they used to call it that, but you just have to know that some people are still in that, slightly old school mentality, and try to not get confused by that. Now that's going to run up our entire femur, right? So up our whole thigh. We're going to go from, the knee all the way to mid thigh, all the way up towards the top, like near our groin. In that region, towards the top of our leg, we're also going to see now this junction of that femoral vein with a profunda vein. Now we usually will call it just the profunda vein because we like to have differentiation with our terms and with our segments of the venous system. But again, you may see some old school texts call it the deep femoral vein. Okay, and it's still considered a deep vein, but just like the femoral vein is considered a deep vein, they had to specify between superficial and deep. It doesn't make any sense, right? So let's consider the main femoral vein that's going to run along the entire length of the femur, the femoral vein. And then there's this other small little segment that's going to kind of drain a smaller portion of our leg. We're going to call that the profunda. Okay, so we're not going to get confused between the superficial and deep. They are both deep vessels. The femoral vein runs the entire length of our leg, of our thigh, whereas the profunda vein is responsible for draining a smaller portion of our thigh that is more so towards the top, near our groin. Okay. We also have another little superficial vein, which is known as our greater saphenous vein, that's also going to dump into that area. Once that greater saphenous vein dumps into that junctional area of the femoral vein and the profunda vein, we now are back to having one vein, which we call the common femoral vein. As we follow that up even higher, now we're kind of like in the pelvis area here. We're going to now see, once it goes, that common femoral vein goes through the inguinal canal, it's going to be termed the oh my gosh, little brain fart. It's going to be termed the external iliac vein. And there's also going to be another little branch of that that's going to drain that bladder and pelvic area. And that's going to be our internal iliac vein. Those are going to join together to form our common iliac veins. Now, if we kind of look at like our aorta protocol, right? Our aorta and our IVC are going to do the same thing, right? We know it kind of splits. So now we're coming up into that bifurcation area where those two common iliac veins, the right and the left, are going to join together to form the IVC. IVC is going to travel all the way up our abdomen. All of the other little abdominal sections are going to drain into the IVC, and the IVC is going to dump right back into the right atrium of the heart. Okay, that was a lot. So this diagram here, I don't necessarily want you to stress too much about this. There's a lot on here. There's a lot going on here, and this is actually just like kind of a general diagram of the venous system of the leg. That's how many branches and tiny little veins we have. But on here, what I want you to really kind of look at is the relationship of the deep femoral vein, which we're not going to call it that, we're going to call it the profunda, and everything that's kind of happening up in this pelvic junction. So this line right here is referencing our inguinal canal. So once the vein travels all the way up and goes through that inguinal canal, now it's going to be considered more of that pelvic venous anatomy. So we're going to see external iliac. We're going to see the internal iliac draining into the external iliac to become the common iliac on that side. The common iliacs from both sides will drain together to form the IVC, right? So really kind of don't get confused with the, the feet in this diagram. Try not to get confused with the calf veins, especially right now, the greater saphenous vein, all of that stuff. Like, I don't need you to know I don't need you to know that. The obturator is just talking about a bone. We don't need to know that. We don't need to know this. We don't need to know that. These three are all branches of the internal iliac vein. They're very small branches that drain very particular areas in our pelvis. So really kind of just looking at profunda joining with the common femoral, profunda joining with the femoral vein here. Greater saphenous is going to join in with those two to become the common femoral here. That's going to travel through our inguinal canal to become external iliac. Internal iliac will dump into the external iliac. It will become the common iliac. It's a lot. I know. So this is a little bit, it's a very blurry picture, but this is a little bit more straightforward in terms of the things that I do want you guys to be aware of. It's a better representation of those calf veins. Again, we're not going to worry about these arches at all, but I do kind of want you to see how the anterior tibial vein, these are paired, so we're going to have two of these, run along the front of the foot, whereas if we look at the posterior view, it runs along the front of that calf, whereas if we look at the posterior view, we see more going on a little bit higher up in the calf, very posterior to that patient's leg. We're going to see the posterior tibials going this way, posterior, and then the perineal also staying posterior, but being a little bit slightly out towards the side. So between those two diagrams, if you can kind of just get like a good general idea of like what the anatomy is in that specific location and like what the relationship is to the surrounding areas, so like what came before it, what came after it. Now, deep versus superficial systems. Our venous system has two different classifications. Our arterial system doesn't. Arteries are arteries, right? Veins, it's a little bit different. Because veins are very so our arteries are responsible really for supplying all of the life-preserving functions necessary, right? It supplies nutrients, it supplies oxygen. It can't really serve any other purpose than that. Whereas our veins, yeah, lower pressure, a little bit more laid back, go with the flow, but they got to clean up everything. So we kind of break it up into levels of importance, right? Which tissues are more important to drain primarily and have more of a direct communication to the heart? Which tissues are a little bit like, all right, we can kind of hang out for, a tiny bit. We could take a detour. We can kind of, hang out with some of our other vein friends, kind of join together to form a bigger vein. So we have these two different systems. We have a deep system, way more important, and then we have a superficial system, not as important. The deep system is going to be the vein that is paired, usually, is going to be the vein that is paired with an artery. So just like our aorta, we have an IVC. We haven't learned it quite yet, but just like our carotid artery, we have an internal jugular vein. Just like our common femoral artery, or like what we learned in lab for our aorta, we have common iliac arteries, we have common iliac veins. Those are all part of the deep system. So they're usually going to have the same name, and the deep system is responsible for 85% of our lower extremity blood volume at any given time. So we always have a lot of blood in our veins and our legs. Usually that's going to be because of gravity, right? So it's going to be harder for our venous blood in our legs to get back up to our heart, and it's a little bit slower. So it takes a little bit longer to get back up to our heart. So we're going to have a lot of blood in all of these veins in our lower extremities. Our superficial system, little less important, little less concerning if there's anything wrong with them. These are not accompanied by a paired artery. So our greater saphenous vein, like we just said in the previous slide, we don't have a greater saphenous artery. It doesn't work like that. The only thing that's a little bit of a gray area is our calf veins. So those anterior tibial veins, posterior tibial veins, and perineal veins, those do have a paired artery, but we still consider those calf veins part of the superficial system. So there are a lot of nuances when we're talking about our cardiovascular anatomy. And then just to kind of, I hadn't mentioned it before, but our veins, specifically in our lower extremities, not only consist of the deep and the superficial system, but there's also these little connecting veins called perforators. So the perforators are little channels that connect the deep veins to the superficial veins. We don't see those on ultrasound, and they don't really serve much of a purpose unless there's something wrong in one of those systems. So if there's a blockage in the deep system, the blood can bypass that blockage, go through a perforator to enter into the superficial system to still be able to bypass and go back to the heart. So we have these little contingency plans in place. We have these little detours in place because of how much our venous system is responsible for in terms of draining. In addition to perforators, which connect the deep and the superficial, we also have tributaries. And because we have so many muscles in our legs, right, even like little muscles that we might not even know that we have, each of these tributaries is responsible for draining the muscle tissue. Our muscle health is very important when we're talking about the venous system in the legs, because we just said that there are muscles that are literally dedicated to helping contract our veins to help send up that blood flow to account for gravity in our lower extremity. So tributaries drain the muscles, perforators connect the two systems. Okay, so tributaries and perforators are not necessarily part of either system. They're kind of these supporting veins. Venous pathology. This we are going to get into much more detail in the fall, but as for right now, you have to have a strong understanding of what a DVT is. It stands for a deep vein thrombosis. Like we said, the deep system is more important than the superficial system. That being said, you can have a clot or a thrombus in the superficial system or in a superficial vein, and it can be considered a DVT if it's within 2 centimeters of the junction with the deep system. And you're like, what are you talking about? So if we go back to here, and we set our greater saphenous vein. Actually, you know what? Let me try this one. So if I erase this, don't mind me. Okay. Try to get some of this junk out of here. I'll use a different color. Okay. So we said that our greater saphenous vein is a superficial vein, right? But at a certain point, it dumps into the area of the deep system. So we have our femoral vein and our profunda vein, right? So our profunda is going to come over here. Our femoral vein is going to come here. They join together. They form the common femoral vein. And then our greater saphenous, even though it's a superficial vein, comes into the play, comes into the mix. So that's where the deep and the superficial communicate. So if you have a clot that's right here, really close to the junction of where that superficial greater saphenous vein dumps into the deep system with the common femoral vein, then we have to consider it a deep vein thrombosis because it's so close. all it would take is one little squeeze or one little augment for that clot in that area to be right now in the deep system. And it's the same thing. If we had a clot in this level of the greater saphenous, okay, well, we don't really care about that because the risk of it traveling into the deep system is unlikely. It's not close enough to get there. Even if it were to travel, it would take a really long time for it to get to that region where it could jump into that junction. So with a DVT, there are a lot of asterisks around it. And let's kind of just pull back up our other slide here. We can have acute and chronic versions. Unfortunately, some people have cardiovascular diseases or pre-existing conditions, of which we will talk about that, make them more prone to clots, or they don't respond to blood thinning medication. So they kind of fall in the category of being a chronic DVT. Those are less likely to embolize. So although they're more long-term and present their own set of complications, the risk of them embolizing is a lot lower than with an acute one. An acute one, it's new. It's not, fully established. It hasn't really made itself at home yet in the vein, so it can very easily dislodge and embolize further up into the system. We are also going to learn about venous insufficiency, varicose veins, congenital pathologies, which means some people are born without valves or they have blood clotting disorders. And then the main risk of having a DVT or really any of these venous pathologies is that you are at a higher risk of an embolism back up to your heart. So mainly focusing on our DVT here. Signs and symptoms, an acute DVT is going to be overwhelmingly painful. Patients can also get muscle cramping in their calf specifically. They're going to get swelling, redness, and erythema. So it's going to be warm to the touch. Now, typically, symptoms, whether it's acute or chronic, are going to be at the level lower than where the DVT is occurring. So if you have a clot in your popliteal vein, right, which is right behind your knee, you're going to feel a lot of those symptoms more distally down your calf. So more in your calf, more in your ankle. Because think about it, there's a blockage behind your knee, but everything is pooling down closer to your toes, right? It can't get through that blockage. So all of those symptoms are going to persist clinically more distal, quote unquote, to where the blockage is. A chronic DVT is any DVT that is unresponsive or undiagnosed for more than 2 months in duration. Literature varies on that. Some people will consider 3 months. Some places consider it 6 months, which is crazy. So we're going to err on the side of most caution and use literature that goes with 2-month duration. Symptoms can be similar to acute, but a lot of that pain and swelling has slightly subsided depending on how long it's gone on for. And now we start to see discoloration of skin. So the skin is starting to be like, okay, like what the heck? Like, when are we going to get this blockage out of here? Like, when is my blood going to be able to travel back normally? So the skin is going to start to kind of wear down over time, and we're going to see all of that like ongoing stasis in the patient's skin. With chronic DVT, we also get ulcerations because of that. So because the blood flow can't move through freely, we have a lot of waste and deoxygenated blood just pooling, right? Because it can't get through. So we're going to start to see the veins becoming a little bit smaller in response, scarred. They're not going to be efficient at bypassing that chronic blockage. And it's going to start to have persistence in terms of like tissue death in the surrounding areas. I am not going to torture you guys with pictures of ulcerations. You can freely Google that if you want, but we will start to see what more of the serious complications look like in the fall. But for right now, some of your patients may come in with their lower extremities looking like this, and these are all appropriate for some version of a DVT. Picture on the left-hand side is certainly going to be more of an acute situation, rapid swelling. Her skin looks very tight on that left leg. If you look at her left foot, it looks very, very puffy, very red, probably would be warm to the touch. We also get what is called pitting edema. So this is not unique to chronic or acute. This can be either version, but basically if you were to push down onto that person's calf or ankle or foot, it would stay pushed in. So pretty nasty stuff. Picture in the middle, we're starting to see this coming more into the chronic phase because we're getting some skin discoloration and the swelling isn't as severe when compared to the other leg. And then this picture on the right-hand side, we could certainly say this person has some sort of chronic condition going on. We are starting to see the skin breaking down in response to that chronic stasis. So pretty soon that skin is going to potentially rupture into an open wound. Risk factors for developing a DVT or really any kind of venous pathology. Predisposing factors are going to be the most likely cause. So as we age, risk increases. If we've ever had cancer, risk increases. Mainly cancer treatment is the risk or the predisposing factor. Chemotherapy and radiation wreak havoc on our cardiovascular system, so it can very easily scar our vessels and make them inefficient. Bed rest or inactivity for any reason, any history of a prior DVT, any kind of trauma, whether it be physical blunt force trauma to the extremity or any cardiovascular trauma. Hormones, this is a big one. We see a lot of young women who come in with the DVT and have no other predisposing factors, but they are on birth control pills. Birth control pills really do change the consistency of our blood volume, so it changes that viscosity, which makes it more likely for the cells to coagulate and accumulate in specific areas. Paraplegia, that kind of goes hand in hand with the inactivity. Any surgery, anesthesia can also have a similar effect on our blood composition, so we want to make sure that post-surgery we are given blood thinners if our surgeon feels like it's necessary. Pregnancy is a big one. It really does, again, change that blood composition. And then also it has a big effect on the return of our venous blood back to the heart. When we learn OB, we're going to learn that as a woman's uterus grows and baby grows, it puts this intrinsic pressure on the IVC. So just by having a baby, just by having an enlarged uterus at that moment, if you're laying on your back, all of that weight is on your IVC, it's going to compress it. So none of the blood flow is going to be able to get back to the heart. So we see a lot of situational symptoms with pregnant women as well. And then any history of thrombophlebitis. Thrombophlebitis is a blood clot in a superficial vein that we don't really care about. Okay, so I didn't say that, but I did say it. So we usually will call it superficial thrombophlebitis. It's really kind of just talking about the inflammation of a superficial vein that now has a clot associated with it. Virchow's triad, this is kind of the clinical checklist that a physician will go off or will kind of confirm a diagnosis. These are going to be the factors that contribute to the formation of a thrombus. So, if you really kind of fall into any state where you would have stasis of your blood flow, that's going to be pregnancy or inactivity, right? So it's slowing down the movement of that venous blood flow getting back to your heart. If you have any condition that's going to put you into a hypercoagulability state, so post-surgical, hormones, that right there, check that off. Any kind of vessel wall injury. So maybe you just had a recent cardiac interventional procedure where they went in and now you have injury to that vessel. Causes of upper extremity DVT. This is very important to note that when we're looking at a patient for a venous DVT, there's really not much of an association because it can affect pretty much anybody, right? So male, female, older, younger, there's so many predisposing factors. There's so many things that can result in a clot forming. But when it comes to the upper extremity, so the veins in our arms, there really isn't much of a cause outside of these situations. So any patient who is undergoing dialysis for kidney failure, any patient who has a chronic illness or cancer treatment and needs a PICC line or a port, those patients are going to be at a higher risk of a clot in their vein, of a clot in their upper extremity veins. But we're usually only seeing clots in upper extremity veins in IV drug users. So it's a very sensitive situation. It's something that we can kind of tell when we're looking at our worksheet or, rather our work list. It's something that we don't want to ever be judging for. It can make our job harder because IV drug users do use pretty much essentially all of the veins that they can, specifically in their arm. So we can see a lot of that scarring, we can see a lot of that clotting, we can see a lot of that thickened vessel wall, and it can make it really hard for us to find the vein and then therefore evaluate it properly. So things that we kind of just want to keep in the back of our mind. Here's our protocol, so you can kind of look over this. We're going to go over this in lab. Don't want to spend too much time on that here. And then there are some specific evaluation rules. When we are doing our protocol, we are going to be starting in transverse, and we use transverse to help us compress. Compression is crucial when we are doing a venous study. If there is a clot in any section of the vein, when we go to compress it with manual transducer pressure, it's not going to compress, right? We can't push out a clot. So it's going to be the telltale sign if there is a DVT or if it's patent, meaning there is no DVT. So we're performing compressions every single 2 centimeters as we're going down the entire length of that vein, all the way from the common femoral at the groin, all the way down to the pop, and then we're also doing it in the calf veins as well. If we see a clot in that groin area, so whether it's in the common femoral vein, external iliac vein, or the IVC, for the common iliac veins, we have to go up even further into the abdomen to see how far that clot extends. So we are looking up at the liver, right? Seeing if the IVC at the proximal region near the liver is clotted. Because if it's clotted distally, it could be clotted mid, it could be clotted proximal, it could be clotted all the way up to the right atrium, right? Chances are it's not going to be because the patient would probably be dead, but still things that we have to know. If we see something, our job is not done. We need to do something else. If at any point a segment of a vein is not compressible, we are not doing augmentation. So we'll talk about augmentation in a second, but the purpose of us not doing augmentation is that this manual pressure that we're putting on the venous system can loosen a thrombus and make it embolize. So it's very important that we're doing our compressions first. You may see some techs who are lazy will compress and then turn sag and do augmentation, and then move down and compress and then do sag and augmentation and move down. That's because they don't want to go up and down the leg twice. You have to do compression all the way down in transverse, make sure it all compresses, and then go back up and do your augmentation all the way down if it was patent. If it wasn't patent, you're not going to do augmentation. The reason why those techs shouldn't be doing that is because just because you're starting at the common femoral and it compresses there doesn't mean that it's going to compress at the popliteal, and you don't know that. So now you've gone the entire length of that leg and you've compressed it you've augmented it probably 5 or 6 times. So you would put that patient at a risk for embolization because you didn't know that they had a clot at their popliteal vein, and you augmented anyway, and you put unnecessary pressure on that clot, running the risk of having it embolize all the way back up to the heart. So very important things that make a huge difference. And like we said previously, any clot that's visualized in a superficial vein, if it's close to the junction with a deep vein, is going to be considered and treated as a DVT. So augmentation. This should only be performed if we've proven the entire vein and the entire leg to be patent through transverse compressions. You will also see techs doing augmentation in different ways. The only true way to perform augmentation is by you manually squeezing their calf distal to where you are doppling. So when we've done our transverse compressions, we're going to go back up into SAG. We're going to do our color Doppler pictures to evaluate those waveforms, make sure it's nice and continuous, responds to respiratory phasicity. And then once we do that, at the same time that we're Dopplering, we're going to reach with our opposite hand. We're going to squeeze the calf below where we're Dopplering, and we're going to watch this augmentation appear on our screen. This is testing the patency of the vein, of the valves in that vein, right? So when we squeeze, we want to see it shoot the blood through, the valve's going to close, and then it's going to return back to its normal waveform. So this is what a good augmentation should look like. We don't want to augment right when our Doppler starts, and we don't want to end our Doppler right in the middle of the augment. We want to see it return back to a little bit of flow. So we like to kind of see it in like the 2/3 range of our spectral window. Here is what our transverse pictures should look like throughout the upper part of the leg. We're not going to spend much time talking about scanning the calf because that's something that we just kind of have to do in person. And you're going to see tech struggle with that even in the clinical world. So you will probably learn it in clinic before we spend a ton of time learning it in class and in lab, but we will get there. So we're starting off in that common femoral range all the way up at the top of the thigh. We don't necessarily have to evaluate the common iliac veins, the external iliac vein. We're really starting below the inguinal canal at the common femoral level. So that's going to be this area here. As we come down a little bit, we're going to see our Mickey Mouse sign. And that's going to be our greater saphenous and transverse joining with our common femoral. As we come down, we're also going to see our profunda vein and a profunda artery. And when we come down further from that, we're now going to be in our femoral vein and our femoral artery, which we're going to follow. It's going to look just like this picture all the way down from our upper thigh down to our popliteal vein. The difference with the popliteal vein is that once it goes behind the knee, it flips, and you'll hear the term pop on top. So that means that typically the femoral vein is usually below the femoral artery, just like in this picture. But when we're now behind the knee looking at the popliteal, our popliteal vein is going to be on top and our popliteal artery will be on the bottom in most patients. Here are what our SAG pictures should look like. Of course, we're going to be Dopplering and augmenting these if it was proven patent. The only thing that I would say is that we want to keep the consistency of our color representation the same. So just like how we learned aorta, where our proximal region kind of goes up our screen, our mid region kind of goes straight across, and then our distal regions kind of come back down on an angle. We want to make sure that as we're changing that angle on our screen, that we are inverting the color flow appropriately. So this picture here, I would say to invert so that it appears blue like the rest of our vessels. This picture down here is showing us our sag popliteal vein. That should also be going up towards our screen. These images will make more sense once we start to do them in lab. Scanning the calf, again, I don't want you guys to freak out about this too much. It's very, very challenging to, one, not only see the calf veins, but two, to know which calf veins are which. So take some time with this. Try to fully understand it. I don't want to stress you guys out about it, but you will be responsible for performing the calf veins. The perineal and the posterior tibial are very similar, right? They're kind of like brothers. Whereas the anterior tibial is kind of like the sister out of the three, right? So you got the two brothers and then you got the sister. Well, they're all part of the same thing, right? They're all the same family, but the sister's the odd one out is always going to do their own thing, right? They're always going to be out to left field a little bit. So the anterior tibials are going to be a little bit different in their behavior and location than the posterior tibial and the perineals will be. And now the gastroc veins are really going to be different in terms of their location and what they look like. So with the gastrocs, we traditionally, like we said, have a medial and a lateral. One is going to drain the medial aspect of the gastrocnemius muscle, right, the big chunky calf muscle behind our leg, and the other is going to be responsible for draining the lateral aspect of the gastrocnemius muscle. Medial gastroc vein is usually going to be a little bit bigger than the lateral because the medial gastroc muscle is slightly bigger than the lateral aspect. And it's going to have a whole network of little tiny vessels that are draining into both of those. So sometimes we can see multiple medial gastrocs. Sometimes we can see multiple lateral gastrocs. But in reality, what you want to do is get one medial, one lateral. I'm sorry, I did that backwards. One medial, one lateral. Now look at if you go a little bit further, right? So say you're scanning slightly lower in the calf, you might pick up 3 medial, 3 lateral, right? And then all of these are going to be too small that we're not going to see and pick up anyway. But it all depends at the level in which you are scanning. Now, also look at these down here, right? If you're scanning it a little bit lower, here or here, you might also pick up, oh, what's that? Oh, what's this? Oh, what's that? So the lower into the calf you go, the harder it is to find and differentiate. You want to either stay at the ankle or up towards the knee, where you can see everything converging and separating from each other. I promise it will make sense once we learn to scan it. And here we have some pictures of what our PTVs and our perineals should look like. Those are usually pretty easy to find. They are paired, so you have two PTVs, two peros, you have an artery for the PTA, and then you have an artery for the perineal artery. So the arteries we're going to see in the middle, veins we're going to see on the sides of that artery, and they're very close to each other. So in transverse, we have all of these vessels here. So PTV is going to be slightly more superficial. Perineal are going to be slightly deeper into the muscle. So we have a perineal vein, and we have PTV, and then we have perineal artery, PTA. When you compress it, veins are going to compress, arteries are not. So here's our perineal artery, here's our PTA. When you turn sagittal, you can see all of those vessels beautifully, especially with color on. So much easier to identify and understand when we can do the hands-on approach. And then ultrasound appearance of a DVT, like we said, an incompressible transverse view of the lumen of the vessel, telltale sign. Also, any abnormal wall thickening. So over here, this picture, great example showing what a chronic DVT is going to look like. It's not this overwhelming blockage of the vein. It's more so, hey, I've got like a lot of clot that's kind of like gathering along the wall here. And then when I go to compress it, it doesn't compress at all, right? That's non-compressible there with transducer pressure. And then here in sagittal, you can see a clot, not fully blocking the vein, but pretty close. And again,